Morning, everyone. At the outset, I'd like to thank the organizers of Tmascon for giving me this opportunity to present here. My topic for today is assessment of citrate reactions and its associated factors among patients undergoing autologous peripheral blood stem cell collection. So, moving to the background and rationale, acid citrate dextrose is a commonly used anticoagulant for apheresis procedures. Although citrate in the blood is rapidly metabolized by the liver and eliminated by the kidneys, cytotoxicity is not a very uncommon phenomenon in peripheral blood stem cell collection, and it can present as tingling around the mouth, face, hands, and feet, lethargy, feeling of sensation of vibration, cramps in hands and feet, confusion, disorientation, carpopedal spasm, muscle tightness, shivering, circumoral paresthesia, etc. And the symptoms and signs are owing to the neuromuscular hyperexcitability because of the decrease in the ionic calcium levels, because it is getting chelated by the citrate. And the citrate reaction will cause discomfort to the patient in a procedure which is already prolonged. That is, usually it will take around 6 hours for a stem cell procedure to complete. So our aim here is to identify what are the factors that are precipitating these reactions, and to take a proactive measure in order to avoid the same. So aim is to assess the incidence of citrate reaction among patients undergoing autologous peripheral stem cell collection procedures. So in our institute, autologous peripheral blood stem cell collection is done using spectropsia apheresis system, and prophylactic calcium administration is routinely given for all the patients in a uniform manner. That is, the first 1000 milligram of calcium is given 20 minutes before the start of a procedure, and for each total blood volume that is processed, 1000 milligram additional oral calcium is given to the patient. And if it's a pediatric patient, we reduce the dose of from 1000 to 500. So initially 500 is given before the procedure, and with each total blood volume, another 500 will be added. And it is a retrospective observational study which was approved by the Institutional Research Committee, and waiver of consent was granted by the Ethics Committee. Sampling was done with 100% enumeration, and inclusion criteria is all the patients undergoing autologous peripheral stem cell collection, and exclusion was incomplete records. And data was collected from the autologous peripheral stem cell collection records, patient's age, and the biophysical profile, lab parameters, and the profile of the citrate reaction was analyzed. So this is the baseline demographics of my population. The study was observed among 115 patients with hematological malignancies undergoing autologous peripheral blood stem cell collection. In my population, 50 were females, 65 were males, and less than 12-year-olds, 9 of them were less than 12-year-old, and 3 of them more than 60-year-old. And maximum number of patients were in the age group 49 to 60, that is 37 patients. And most of the cases that we did was multiple myeloma, that is 56 patients. We have also done 38 cases of relapsed Hodgkin's lymphoma, 8 cases of neuroblastoma, and we have also done 4 cases of diffuse large B-cell lymphoma, anaplastic large cell lymphoma, Poem syndrome, cutaneous T-cell lymphoma, and mixed phenotype acute leukemia. And of this, 13 patients developed a citrate reaction. So the profile I have categorized into 2, category 1 and 2, based on the DGHS classification. So category 1 patients developed tingling of face and limbs, and 6 of the patients out of the 13 developed category 1 reaction, and category 2, 7 of them developed that. And in that, all 7 of them had circumoral paresthesia, and 2 of them had circumoral paresthesia along with vomiting, and 2 of them had muscle spasm along with circumoral paresthesia. And all of these could easily be managed within the blood center, and it was managed with 1000 milligram of additional oral calcium at the time of reaction. And in patients who developed vomiting, we had given IV calcium gluconate 500 milligrams slow infusion. And coming to the patient characteristics in the citrate reaction and non-reaction group, when we are checking the median age, there was much difference. And when it came to gender, 2 out of 65 males developed the citrate toxicity, and 11 out of the 50 females developed the citrate toxicity. So p-value there was significant. And the serum calcium level in the baseline during the initial assessment of the patient, in the citrate reaction group, we have found that it was slightly lesser compared to the no citrate reaction group, that is 8.19 in the citrate reaction and 9.07 in the no reaction, and this was found to be statistically significant. And serum creatinine and albumin values did not show much difference among the citrate and no citrate groups. And we also assessed the comorbidities, and CKD is a comorbidity which can predispose to citrate toxicity, but none of the patients with CKD developed a reaction. And most of the reactions were in patients with multiple myeloma, obviously, because the number of cases we did were much higher. And 6 of them developed a reaction, and 2 of the 38 patients with relapsed Hodgkin's lymphoma had developed a reaction. And a number of patients' blood volume that was processed was slightly higher in the citrate reaction group, that is 3.04 compared to no citrate reaction group. Although the p-value was not significant, and the duration of procedure was almost similar in both the groups, and the volume of ACD was slightly lower in the citrate reaction group, obviously because most of them who had citrate reaction were females with a lower TBV, and thus the ACD volume that the machine calculator would have been lower. So moving on to the discussion, out of 115 patients observed, 13 patients developed citrate toxicity, and it is much less compared to other studies, probably because of the prophylactic calcium coverage and factors like alkalosis, type of anticoagulant solution used, ACD, and the rate of infusion of anticoagulant, the amount of citrate infused, volume of blood processed, age, gender have already been proven to be factors associated with citrate reaction. But in our study, we have found that female gender and the baseline serum calcium levels were significant findings. So concluding, female gender has been identified as a factor contributing to citrate toxicity. Hence, proactive measures to supplement calcium during procedures can decrease the discomfort of the patient, and lower baseline serum calcium level should be identified as a factor for developing citrate toxicity, and hence we need to take calcium supplementation during the procedures for avoiding the patient discomfort. So the limitation was, mine was a retrospective study, and there were a few lacunae in the recordings, like the return speed, the draw speed, the rate of infusion of ACD, and changes in the ACD ratio made, if any, during the reactions were not available. And these are my references.
Thank you, Haripriya. How did you manage the citrate toxicity other than by giving oral?
Actually, ma'am,
Other than oral calcium, any other measure to tackle this citrate toxicity?
We have, it has not been documented what has been done, but usually in our institute, we will decrease the return flow rate, and also we'll usually decrease the ACD ratio.
Okay. Other than oral calcium, any other way by giving something you can do this?
We sought for IV
Orally only.
calcium.
IV. What is the
Only
dose? What is the route and dose?
We start with a 500 milligram calcium gluconate infusion in 100 ml normal saline, slow infusion over 1 or 2 hours.
500 you give.
Sir?
How much you give?
500 we'll start with, and we'll see whether the patient is responding. And if needed, we'll give additional dose.
Okay.
Another 500.
Okay. This was a retrospective study.
Yes, ma'am.
Okay. Completed in 23.
Yes, ma'am. From 2020 to 2023.
Okay. Okay. Can you tell me something about the citrate metabolism? How that is metabolized in the body?
Citrate is metabolized by liver, and the metabolism takes place within some 15 seconds. 15 minutes. So the rate of the rate of citrate is going to come down in our system very fast.
Okay. Okay. Any questions from the audience? Okay.
ലാസ്റ്റ് തരാം.
Good morning, all. First of all, I would like to thank the organizers for giving me this opportunity. Myself, Dr. Arun Naik VS, a junior resident in the department by IHBT, Jubilee Mission, Thrissur. My topic is impact of early fibrinogen replacement using cryoprecipitate transfusion in patients with postpartum hemorrhage, a retrospective study. Moving to the introduction part, postpartum hemorrhage remains major cause for maternal mortality and morbidity. Management of severe PPH include administration of pharmacological, surgical intervention as well as blood transfusion. Replacement of coagulation factors is crucial in achieving hemostasis and thus controlling the bleeding. Several studies demonstrated that fibrinogen level drops early and significantly in PPH. The fibrin strands that form in a low fibrinogen environment are more susceptible to fibrinolysis. And this fibrinolysis has been identified as a major component in PPH as well as massive hemorrhage-induced coagulopathy. Moving to the aim of my study, it was to study the impact of early fibrinogen replacement using cryoprecipitate transfusion in patients with postpartum hemorrhage. Moving to the materials and method, it was a retrospective observational study conducted for a period of 12 months from July 2022 to June 2023 in the Department of IHBT and Gynecology, Jubilee Mission Medical College, a tertiary care hospital in Kerala. The patients presented with PPH requiring cryoprecipitate transfusion were included in the study. Then the patients were categorized as receiving products based on goal direct therapy, that is by means of ROTAM, versus based on massive transfusion protocol or by conventional coagulation test. The ROTAM group received early fibrinogen replacement while the other group received later fibrinogen replacement after conventional coagulation test. Moving to the clinical outcome indicators, it included duration of hospital stay, PRBC units transfused, FFP units transfused, platelet units transfused, and cryoprecipitate units transfused. Moving to my result, the study population included 19 patients. The goal-directed therapy, that is by ROTAM, was given to 11 patients, and they received early fibrinogen replacement in the form of cryoprecipitate transfusion. The remaining 8 patients received multiple transfusion, including later cryoprecipitate transfusion, after the results of conventional coagulation parameters. Comparing the duration of hospital stay among the ROTAM group and the conventional group, the mean hospital stay among the ROTAM group was around 8.09 days, where in the conventional group it was 8.62 days. It is clear that early fibrinogen replacement has minimal impact on reducing the hospital stay. Comparing the use of blood products among the two groups, regarding the PRBC usage, it was around 3.72 in case of ROTAM group and it was around 5.12 in case of conventional group. Regarding the FFP usage, it was 1.27 units in the case of ROTAM group. It was around 3.37 in the case of conventional group. Regarding the platelet usage, it was 1.90 units in the case of ROTAM group and it was around 3.75 units in the case of conventional group. The cryoprecipitate transfusion, it was around 18.63 units in the case of ROTAM group and it was around 18.75 in the case of conventional group. Thus, it was clear that in this graph we can show it is clear that more products being consumed in the conventional group and the ROTAM group received much lesser products. Moving to the discussion part, the normal hemostasis is critically dependent on fibrinogen as the substrate for clot formation. PPH is associated with low fibrinogen levels, which can lead to coagulopathy and increased requirements of blood products. Charbit et al. Demonstrated that plasma fibrinogen at enrollment was a predictive factor for poor outcome in 128 women with PPH. Malay et al. Made comparison of usage of massive transfusion strategy versus use of adapted dose of fibrinogen concentrate in coagulopathic PPH diagnosed by point of care devices. They demonstrated that significant reduction in number of patients requiring more than 6 units of PRBC and in overall blood product requirements and in maternal morbidity while using point of care devices. In our study, 11 patients received early cryoprecipitate transfusion according to the ROTAM algorithm and they required less number of blood products. Thus, point of care, that is ROTAM, can be used to detect coagulopathy and thereby aid in early fibrinogen replacement and need for minimal blood products. Moving to the conclusion part, early correction of PPH associated coagulopathy is expected to contribute to better management. Fibrinogen replacement using goal-directed therapy, that is by ROTAM, appears to be one of the promising targets for this hemostatic intervention. Following goal-directed therapy reduces unnecessary transfusion. Early fibrinogen replacement by cryoprecipitate aids in better patient management. These are my references. Thank you.
Thank you, Arun. So you recommend point of care testing for all the institutes, if affordable?
If it is affordable, it will be better, ma'am.
Okay. How did you calculate the volume of cryoprecipitate? You just
Usually, in
calculated-
our institution, we for a bleeding patient, we directly give 10 units of cryo.
Agree. How the quantity of cryoprecipitate in each product may differ, no? In each unit.
Is unit, yeah,
in
ma'am.
ml.
ML,
Have you quantified?
Approximately, it will be around 18 to 20.
So not quantified. Volume
Ma'am, I
not
did-
calculated. Volume of cryoprecipitate not calculated. Just the number of units you calculated in your study.
Yes, ma'am. Yes, ma'am. Only the units are.
Only the units
Only
are
the
calculated.
calculated.
Ideally, it should be pooled and the volume should be measured. The approach that would be more accurate, I think.
Okay, ma'am. Okay.
Then another thing, any calculation, any scope for calculation of p-value is important.
I have approached them because since the population size was, the study population was only 18, it was very difficult to compare the two groups. That's why
Between the two groups.
there was
This is only a retrospective study.
a retrospective
In PPH, this duration is 1 year.
1 year. ma'am.
1 year.
Mm.
I think a suggestion from my part, you could have done for a prospective monitoring.
Monitoring.
That would have been much better when you
Yes.
utilize this ROTAM and all.
Okay. Mm.
Prospective, in
Prospective
prospective study, the intervention using point of care testing, expensive tests, which have been much useful.
Okay, ma'am.
Any questions from the?
I hope this is an ongoing study.
No, ma'am. No, sir.
Completed.
Actually, I approached for a prospective study, but since the gynecology people are not very interested, because I have to collaborate with the gynecology department also, sir. Because some of the consultants are reluctant in using this
So in
point
the
of care.
retrospective study, how did you have two groups? Like some patients were treated with ROTAM, some patients were not
Yes, sir.
treated with ROTAM.
Yes, sir. Because some in our institute only some consultants are using this ROTAM.
Consultant based.
Yes, sir. Even though we suggest, they will only.
So I didn't understand one thing. You ultimately your study aim was to tell whether
Early fibrinogen.
early fibrinogen, but your study title does not tell that. It just says impact of fibrinogen. Why is it right?
The study title was not appropriate, sir.
No, I'm not telling appropriate. Why I'm telling is you have done a more specific study.
Yes, sir.
Here your intention is to say, see, everybody received fibrinogen. The difference here is based on ROTAM they received earlier or as a protocol they received later.
Oh, yeah. Yes.
But when you depicted it, you just said impact of fibrinogen. Impact of early fibrinogen. Maybe ROTAM or based or
Okay, based.
that should have come here.
Yes, sir.
That
Sure,
is-
sure,
that
sir.
is
Thank
fine.
you.
Not part.
No, sir. No, sir.
requirement. No? These
Sir,
things,
actually, when a coagulopathy starts, there will be consumption of products, and it will lead to more amount of blood is lost. So, when more amount of blood is lost, they will require more transfusions. Yes, sir. I didn't. It was only a retrospective study, so I was not able to collect them. Maybe in the prospective study, it will be much better for screening this kind of.
so your outcome post-operative, like your clinical outcome is only the number of units transfused.
Yes.
Whether this patient survived or developed any coagulopathy later, you did not assess.
Actually,
This is intraoperative, right?
Huh?
Intraoperative.
is this a retro?
Intraoperative setting, right?
Yeah.
So post-operatively, whether they survived or not, did you assess?
Actually, there was no mortality compared to in
This is
the
the entire hospital transfusion, or it is only that point of PPH times transfusion?
only the PPH patients required who required cryoprosthetic transfusions.
I understood. Like my point is, these number of units, no, they were captured at the point of hemorrhage or during entire hospital admission.
Sir, after entire hospital admission. During PPH, during the first 2 days. Because most of the patients came as a reference cases. Sir. So after they developed bleeding, from their date 1 to then 24 hours, we will issue this.
That's what. This is 24 hours unit transfusion.
Yes, sir.
Okay. So you could also compare the until the admission, what is the number of whether they develop coagulopathy or not.
Okay, sir.
Because here you have given more components in conventional, in ROTEM number of less components.
Yes.
So how many develop coagulopathy after this event? The time of this before discharge, any further transfusions required also you can add.
Okay, sir. Okay.
But this is 24 hours now. That's what
24 hours only, sir.
hospital stay was same.
Come,
One more.
sir.
No, you can add additional outcomes also.
Oh, yes, sir.
Number of units.
Okay, good.
Okay, sir.
Thank
Thank you.
Thank you.
Okay. Hello? Okay.
Good morning. I would like to thank TMAS organizing committee to that have given me the opportunity to present this case, a case of lead poisoning secondary to the intake of herbal medicine for diabetes mellitus, a case report in the tertiary care hospital in Kerala. Myself, Dr. Jin Thomas, junior resident to Department of IHPT, Jubilee Mission Medical College, Thrissur. Contents, we will be going through the introduction, brief history, clinical examination, laboratory finding and imaging, case development, diagnosis, conclusion, and takeaway messages. So the introduction is, Ayurvedic medicine, as we know, is a traditional system for from India, which emphasizes on plant-based treatment and incorporates minerals like sulfur, arsenic, copper, gold into its formulation, and these metals are believed to be crucial for body's vital molecules. Some Ayurvedic preparations have been found to contain lead and or mercury at 100 to 10,000 times greater than the acceptable limits. So here is a case of lead poisoning secondary to the ingestion of Ayurvedic capsule or herbal medicine through which was procured through online. So coming to the history, a 58-year-old female with a history of type 2 diabetes mellitus and hypothyroidism presented to the medicine OPD at JMMC with complaints of generalized tiredness, decreased food intake for 2 weeks. She also complained of abdominal pain for 2 weeks after taking food, and it was not associated with nausea or vomiting. She has no history of fever, loose stools, breathing difficulty, melena, hematemesis. She was comparatively healthy prior to this illness, and she was previously on metformin, which she stopped 2 months back, And she was also taking thyroxine tablets, 50 microgram for her hyperthyroidism. On examination, she was conscious and well oriented. Pallor was present, no icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals were recorded within the normal limits, and the oral examination revealed a desquamation of tongue and oral mucosa. All other systems were within normal limits. So you can see this is the lab investigations. I have highlighted that the HP was 7.5, hematocrit 23.1, the tick count was 7.94, and SGOT was 139, and SGBT 146, and iron was 182 microgram per deciliter. On further evaluation, the blood lead levels were much elevated, that is 121.2 microgram per deciliter, and also in the urine 400.2 microgram per deciliter. The herbal capsule was also tested, and it was found to have 10,000 times more than the permissible limit, that is 40,657. So, highlighting the abnormal findings, that is hemoglobin was 7.5, hematocrit 23.1, reticulocyte 7.94, SGOT 139, SGPT 146, serum iron was 182, and lead levels were highly elevated. Diagnostic imaging, USG abdomen, no abnormalities were detected. In the peripheral blood smear, there was coarse basophilic stripling, normoblast, polychromasia, indicating normocytic normochromic anemia. You can see the picture that is shown here shows basophilic stripling. On bone marrow examination, it showed erythroid hyperplasia with many ring sideroblasts in the aspirate, demonstrated by Pearl's Prussian blue stain. Now, on re-evaluation of the patient, it revealed that the patient was taking herbal medicines for glycemic control, which was procured via the internet for 1.5 months and which was stopped prior to the admission. The name of the drug company is written, and on further testing, we found out that high levels of the lead in blood and urine was found, and the herbal medication also was tested, that is 40,657 parts per million. So we concluded that the patient had lead poisoning due to herbal supplementation and leading to acquired sideroblastic anemia with consideration of myelodysplastic syndrome with ringed sideroblast. Treatment, she discontinued the herbal medication. We initiated her on chelation therapy with BAL and followed by D-penicillamine. Symptomatic improvement was observed and hemoglobin levels increased to 10.1. She was continued oral D-penicillamine for 6 weeks and leading to normalization of blood and urine lead levels. So on discussion and conclusion, lead exposure potentially from herbal supplements can significantly impact health, leading to symptoms like abdominal pain, fatigue, and more severe conditions like sideroblastic anemia. The acceptable blood level lead levels are less than 25 microgram per deciliter for adults, with this case significantly exceeding these levels. Chelation therapy is recommended for blood levels greater than 80 microgram per deciliter in asymptomatic adults and greater than 50 microgram per deciliter in symptomatic adults. This case underscores the importance of careful evaluation of herbal supplements and public awareness of their potential risks. So the takeaway message is enhanced vigilance and awareness are crucial in preventing heavy metal poisoning from seemingly harmless herbal supplements and emphasizing the need for regulatory oversight and patient education on the risk associated with unverified herbal medication use. Thank you.
Okay, Janet. Unverified use of medications are always to be checked. No.
Yes.
Here, your presentation is on lead poisoning, which affected kidney.
Okay.
Is it so?
No, actually, the patient came to us with generalized tiredness, ma'am. Her HP was not
Will
improving.
it cause nephropathy?
Yes, yes.
What is lead nephropathy?
Lead induced.
What is the deleterious effect if lead enters into circulation? Which organ will be affected and how?
Madam,
Can you explain?
it can cause liver.
Regarding the laboratory values, have you checked what all things? Can you show that slide again?
Yes.
Lab results. Okay. Hemoglobin, hematocrit,
Yes.
PCV, Paxil, MCV. MCV, is it important to check MCV? No
Yes.
idea.
Yes.
Can you tell me other conditions in which you get the other effects of lead poisoning other than this?
Lead poisoning can cause signs of lead poisoning. One is Bartonian lines. It can affect. It can cause hepatic damage.
Okay. Anyway, your message is good that judicious use of medicines to be
Yes.
there. Question from the audience.
Yes.
They come under hypochromic anemias, no? So why retic count is high in this case? Did you do direct antiglobulin?
It is normocytic normochromic anemia with basophilic stippling, no? That is why sir is
No,
asking.
retic count is very high, no, in this case. So usually sideroblastic anemia, they present with normal retic or low retic count. So did you do that in this case? Can it be drug-induced hemolytic anemia?
That was negative, sir. DCT was negative on this patient. Actually, this patient also received 4 units of PRBC transfusion
Understood.
prior.
But
And
the
actually
cause for retic is not explained in this, no?
no. But on the peripheral blood examination, we found out that there was basophilic stripling, which was a sign of lead poisoning.
Yeah, no wrong, nothing wrong with the diagnosis. I'm just asking, is there any coexisting hemolytic anemia to cause a retic high?
We didn't evaluate.
One-time event, no? This is not a chronic poisoning. Or is it
What's that?
chronic?
No.
1.5 months.
1.5.
Only thing is like, how is it relevant to transfusion medicine? No, there is some relevance. Plasma exchange may be in acute poisoning. Okay.
Thank you. What's it? And supplementation was no. No, they didn't start anything. They didn't start. They actually they transfused, but HB was not. She was not supplemented with iron. Yeah.
At the outset, I would like to thank the organizers of Tmascon for giving me an opportunity to present here. Myself, Dr. Linda. Moving on to topic, it's evaluation of protocols for the preparation of platelet fibrin. Moving on to the introduction, as you all know, PRF is a second generation autologous platelet concentrate, and the first generation is
platelet plasma. This is the second generation. It's a fibrin-based biomaterial developed by Chowkron et al. In 2001. He used this in oromaxillofacial surgery. And later, since last 20 decades, we have been using this for in place of regenerative medicine for tissue wound healing. So as you all know, when the platelets get activated, it releases various growth factors like PDGF, VEGF, EGF, TGF-beta, and these are capable of inducing angiogenesis and tissue wound healing. This is used in many fields of regenerative medicine. So moving on to the objectives, the primary objective is a comparison of two PRF preparation protocols. The first PRF preparation protocol is 700G for 8 minutes. Next is 1000G for 8 minutes based on the platelet yield. And the secondary objective is a comparison of protocol which has been used in our center, that is 1613G or 3000 RPM for 10 minutes with the above mentioned protocol. Moving on to the material methods, this is a prospective study done in 10 volunteers, including 5 males and 5 females, a duration of 6 months. The inclusion criteria includes healthy males and healthy males and females. Exclusion criteria included volunteers with abnormal CBC, smokers, bleeding disorders, and those who are taking antiplatelet drugs. So a total of 18 ml was collected with the help of a butterfly scalp needle from each volunteer. And this 18 ml was transferred into 3 different EDTA tubes in 6 ml. So 6 ml EDTA, 3 different tubes was centrifuged in the Nair centrifuge, which is a horizontal centrifuge. Before taking for centrifugation, a baseline CBC analysis was done in Tmascon automatic analyzer. After the CBC being done, these samples are taken and then centrifusions done in 3 different protocols. Our first protocol was 1613G, that's the highest spin. The next protocol was 1000G for 8 minutes. The third protocol was 700G for 8 minutes. And then after the centrifugation, this blood sample will settle down into, as you all know, based on density into 3 different layers. The topmost being the plasma layer, the second layer is the buffy layer, and the third lowermost layer is the PRBC layer. And from each layer, we do sequential pipetting into 3 different ependorf tubes, and we label it as PRBC, buffy, and plasma. And from each layer, we do the CBC analysis using automation, Tmascon analyzer. So a total of 100 CBCs were done from these 10 volunteers. And after that, a 6 ml blood was collected from each volunteers. We have done only this Leishman staining in 3 volunteers out of the 10 volunteers. The 6 ml sample has been transferred to 3 Tarsen tubes, and centrifugation is done in 3 different protocols. After the centrifugation, a smear is prepared from each layer of plasma, buffy, and PRBC, and slide is prepared using Leishman stain, and platelets counted manually. So how you do the platelet counting from the Leishman stain, after Leishman staining is prepared, we do the counting in the 100 ml oil immersion. We count the 10 fields and we multiply it with 15,000. So platelet count is done manually. The next one, what we did is a 10 ml blood is collected in each of, again, 3 Tarsen tubes from 3 volunteers, and centrifugation is done in 3 different protocols. And after the centrifugation, it will settle down to 3 layers, and from each layer, that is PRBC, plasma, and buffy, from each layer, we did a clot formation, and it was fixed with 10% neutral buffer formaldehyde, and was taken into the automatic tissue processor where the paraffin embedded section was done and staining was done with hematoxylin and eosin stain. So for why we did this is for studying the cytological evaluation. So moving on to the results, if you look into the cell division pattern obtained this using first protocol, that is 1613G, the highest speed. With this protocol, we got the maximum platelet and WBC concentration in the buffy layer, that is the middle layer, whereas a lesser concentration was observed in the plasma layer. And in PRBC layer, the cell concentration was much lesser than the buffy layer, but it was greater than the plasma layer. The average plasma volume was around 3.2 ml. If you look into the distribution pattern in the next protocol, that is 1000G in 8 minutes, whatever cells was there in the previous protocol in the buffy layer has moved from the middle layer to the topmost layer, that is to the plasma layer. So the maximum number of platelets was observed in the plasma layer in the second protocol, and the WBC was maximum seen in the buffy layer. If you look into the cell distribution in the third protocol, that is 700G in 8 minutes, the maximum number of platelets and WBCs was observed in the topmost layer, that is the plasma layer. Whereas In the first protocol, in the maximum speed, that is 1613, the maximum number of platelets and WBCs were seen in the buffy layer, middle layer. So when the speed and centrifugation we reduced into 700 G, the platelets started moving from the middle layer, buffy layer to the plasma layer. Now moving on to the, this is the picture showing the mean platelet concentration, the plasma, buffy and the RBC layer in the three different centrifugation protocols. If you look into that, the baseline is showing a mean platelet value of 281 and the yellow bars are showing the mean platelet counts in the plasma layer. You can see the maximum platelet concentration in the third protocol, that is the lowest spin, 700 G for 8 minutes, that is showing a 576,000 platelet count. The maximum platelet concentration is seen in the plasma layer. Whereas in the buffy layer, the maximum platelet mean concentration is seen in the buffy layer in the first protocol, that is the 1613, 3000 RPM. And the if you look in the PRBC, the maximum platelet concentration is seen in the first protocol, that is 1613. But the maximum concentration in the plasma layer seen in the third protocol, that is 700 G in the low spin. If you look into the WBC concentration, mean concentration, if you compare with the three protocols in the three layers, here you can see the third protocol, again the 700 G for 8 minutes showing the maximum platelet concentration of, WBC concentration of 64.5. If you compare with the baseline is showing 8.83, but whereas the blue bar is showing the maximum WBC concentration of 64.5 in the third protocol, that is 700 G for 8 minutes. So the mean platelet and WBC value using three protocols, each were compared with the baseline. So it showed a platelet and WBC count resulted in a significant p-value. This is a picture showing a comparison of median value of platelet and WBC counts among the three protocols with 3 layers of blood. So there was a significant difference noted in the platelet concentration in plasma, platelet concentration in buffy, platelet concentration in PRBC, and also WBC concentration in plasma. This is what we did in the manual count using a peripheral smear. Here, if you see, we can see a significant increase in the platelet count by manual method in 700 G for 8 minutes if you compare the whole 3 different protocols. We have done the cytological examination of PRF also. If you look into the 3 smears, you can see the 700 G is showing a maximum number of platelets in the plasma layer. This is 700 G 8 minutes cytological examination. This is the first picture showing 1000 G, second picture showing 1613, where you can see maximum platelets in the plasma layer. So moving to discussion, the study was conducted to optimize 3 PRF preparation protocols. The best quality protocol was identified based on the cell count, the cell distribution pattern. The best protocol was identified as 700 G. In that, it goes along with the lines of R.J. Miron et al. So in that study, 24 protocols were compared and found that optimum centrifugation speed and time for solid PRF ranged from 400 G and 700 G for 8 minutes. Variability in patient count significantly affected cell separation. There was a 2 to 3-fold increase in the platelet concentration from baseline count was achieved using the protocol 700 G for 8 minutes. And 3.5-fold increase in platelet numbers was also reported by R.J. Miron et al. As the speed and time increases, the cells have a tendency to move towards the lowermost layer in the PRBC layer. So to conclude, the present study compared the 3 protocols by means of platelet concentration, cell distribution, and found that the lowest spin, that is 700 G for 8 minutes, is the best among 3 protocols. Thus, our study concluded that the platelet yield is more pronounced in low centrifugation protocols in vitro, and more clinical studies are therefore required for determining the clinical effects of various protocols. So limitations includes the quantification of cells is not possible in PRF. We studied it in the PRP as a representative sample for doing the CBC analysis, and manual cell counting using Leishman stain we did in only limited volunteers of 3 based on the high platelet counts. Thank you.
Thank you, Linda. So you made a comparative study.
Yes, ma'am.
Made a comparative study between the 3
Three different
methods of
protocols.
getting
3 different protocols.
platelet
Yeah.
preparation for regenerative therapy. Is regenerative therapy being done in your institute?
Yes, ma'am. It's been
For
done
which all conditions?
for
you do?
maxillofacial surgery and for diabetic wound healing, and also for anophyseal rectal surgeries. We are using it. for-
Average, how many cases per year or
Around
per
we
month?
get 3 cases per week, 3 to 4 cases
So
per week.
frequently you are doing.
Yeah, frequently we are
So
doing.
the quality is assessed by, quality of preparation was assessed in your study by
By platelet count.
Not
First one was
by
the platelet count
platelet.
using a CBC
The
analysis.
quantification of PDGF not done.
That was not done.
Not done.
None. Actually, because of the financial problem, we didn't do. We have the kit for doing ELISA. We got it recently. We'll be doing
Actually,
it.
the quantity of the platelet derived factors that
Yes.
is more important than the count. Is that
Count.
so?
Yeah. Yes, ma'am.
Yes.
Yes.
Then which machine you're using?
It's actually we are collecting the blood samples and we're doing it in the Tarson tube. It's not done being automated method. We're doing it manually only, ma'am. The automatic kits are available, but we are not doing in the
The
automatic kits.
speed of run varies with all the three.
Pardon, ma'am?
The run speed differs in all the three
All the
methods.
three, yes, yes.
From where did you
Actually,
get
we
this?
were doing in the highest spin, 1613 or 3000 RPM. We compared it with the mother article, the standard protocol, 700G and 1000G. So we found that the lowest spin, that is 700G,
That is why you
much
selected those runs.
Yes,
What
ma'am.
about the third run?
Third run was 700G. That was the best protocol when I compared with the RJ Miron et al. He has done only one study is there regarding this protocols. That is RJ Miron
The
et al.
third
study.
run, you said it is 1600.
Third run is the 700G, ma'am. First run is 1613.
What is the reference for that?
1600 reading 3000 RPM was done in most of the centers. It's been done. In 3000 RPM, that was done in the previous studies. But recently, a new study has done by Arjimeron et al. In 2020. In that, he has mentioned the protocol as 700G. He has compared around 24 protocols. Like he has done that study with 6 centrifugal speed with 4 times.
750 and 1613 you said, no?
Yes, ma'am.
That is the, what is that reference?
That was done by Miron et al. Years back. He has done several studies since so many years. So the recent study, he mentions it as the best study protocol as 700G.
Okay. Comments from the audience?
Yes, ma'am. Yes, sir. Yes, sir. Yes, it was given to, no, we have, this is a donor population. We have done our another department, gastrosurgery department, they have done a similar study in the patient population also. That is for liver transplant. They prepared this PRF in this different protocols and they they've taken this PRF for liver transplant as a graft. For enhancing the
In our
graft.
center also we are doing this PRP therapy and we are doing the same.
ma'am.
I expect a comment from Dr. Shanavas. He has done a lot of work on this. Come on.
Thank you.
But you have gone through all the aspects of the PRP therapy and you going to the next generation of PRF. And I just want to know, what do you do with this PRF with respect to liver transplant?
Actually, what they've done is they've taken this PRF and they've grafted in the pedicle. When you do the liver transplant, no, that's the liver pedicle, no. They have kept it there. What they say is it enhances the tissue repair.
You're telling on the portal triad, where portal vein system you were trying to tell me. Oh, biliary leak. Okay, fine. Okay, understood. That's actually a real complication. That actually.
Yes, immediate surgery.
Fine. And you are giving with this calcium chloride, or you are giving like this only?
Like this only. We are
Like
not
this.
providing calcium. Like this only.
This is an open method.
Actually, they are keeping this machine in the OT, near the OT.
Fine.
And they are
Okay.
preparing it there
Okay.
and they are transferring
Yeah.
it
Okay.
like that.
Then fine. Then it's okay.
Thank you.
A warm good morning to one and all. I would like to thank TMAS and Tmascon for giving me this esteemed stage to present my case report. Navigating the enigma of refractory immune thrombocytopenia in pregnancy, a maternal challenge. Myself, Dr. Akshay R., junior resident from Jubilee Mission Medical College and Research Institute. Without much delay, I'll go to my case. She was a 25-year-old female G3A2 at 27 weeks of gestation who presented with to our hematology OPD for treatment of ITP. In the past, she had petechiae over the upper and lower limbs. She also had occasional bleeding from the gums while brushing. She was also on treatment for overt diabetes and hypothyroidism. She had a family history of type 2 diabetes in her parents. She attained menarche at 12 years of age and she was married for 5 years. She has had two occasions of abortions, but the cause was not evaluated. On examination of the patient was stable. There was no bleeding manifestations. Not like that. She was having petechiae over her left upper limb, but all other systems were within normal limits. Course in the hospital, we admitted the patient as the platelet count was 8,000. We started on her with injection dexamethasone 40 mg IV OD for 4 days, and serial platelet count monitoring was done. The platelet count ranged between 8,000 to 10,000 during that period. According to the consent from the gynecological side, we started on her with random donor platelets. 4 units were transfused. And the platelet count initially went up to 15,000. On the 4th day of her admission, she had an epistasis. Then also from the gynecological side, they wanted 4 units of RDP and it was transfused. The patient was shifted to the CCU and she was given 1 unit of IVIG, 50 grams, and the platelet count went up to 20,000. When the patient was stable, the patient was shifted to the ward. TAP mycophenolate mofetil was started, but later it was discontinued. So we started on her with injection rituximab, 100 mg IV for 2 weeks. At that period of time was our period of concern because her platelet count ranged between 5,000 to 8,000. Again, we started on with injection romiplastin, 250 microgram, 0.5 ml per 0.5 ml subcutaneously weekly. So 5 doses, that means 5 weekly we gave her. At 35 weeks, we saw that the CTG showed high baseline values and poor variability. So induction of labor was initiated and also NICU counseling was given. At that time, it was, I think that was the time when we were all at tension. So we ourselves arranged SDPs, and luckily we could transfuse her with 4 units of SDPs at the time of induction, during induction, and at the time of delivery and postpartum. And the platelet count went up to 50,000. The patient delivered by normal vaginal delivery, live female baby of 2.63 kilogram. This was her initial workup. We can see that her blood group was A positive and ANA profile and APLA profile was negative. This is the whole hospital stay of the patient from day 0 to day 55 at the time of delivery. These are the different drugs that I mentioned earlier, and all throughout this time, corticosteroids were supportive medicine for this patient. At time of discharge, we discharged her with TAP prednisolone and azathioprine. When we come to the case of the baby needed NICU admission for respiratory distress and also non-vigorous at birth. The baby required CPAP for 12 hours and off supports thereafter. On blood investigations, we saw that the platelet count went down to 20,000. Initially, the baby had 30,000 at the time of delivery, and within 3 days, the platelet count went down to 20,000. And 2 units of RDP was transfused. The baby also had jaundice and phototherapy was initiated. At the time of discharge, the baby had 50,000 platelet count. This was the initial evaluation of the baby, and we can see that from the peripheral smear, there is severe thrombocytopenia. This is the platelet trend of the baby. At day 0, it was 30,000. It went down to 20,000 in day 3, and it went up to 50,000 at the time of discharge. So what is thrombocytopenia? Thrombocytopenia is characterized when the platelet count goes less than 1,50,000. And ITP, we commonly say that when the platelet count goes down to 1 lakh, less than 1 lakh, and it can be a typical reason for thrombocytopenia in most pregnancies. So it is since it is a disease of heterogeneity and also lack of diagnostic indicators, the treatment is difficult. We start a patient with corticosteroids and IVIG. That is the first line drugs that we give. Moving on to the international consensus report, it recommends that platelet count below 20,000 in first and second trimesters, the steroid should be initiated. Why is it so? Because it inhibits the phagocytosis of the opsonized platelets, and also it causes an impairment of the autoantibody production. Then comes IVIG. According to the ASH guidelines, it's said that we can give it for severe thrombocytopenia. But the problem with IVIG is that multiple doses may be needed because of its transient response. So what happens? The cost of treatment goes up, and that can cause patient inconvenience. Azathioprine and cyclosporin are also used in pregnancy, but the problem with it is that there is a slow initiation of activity. Mycophenolate mofetil is also added with glucocorticoid because many studies have shown that the refractiveness and the relapses are lesser in these cases. Elective treatment with rituximab, which is an anti-CD20 monoclonal antibody, it gives an overall response of 62.5%, and it can last from 2 to 48 months. Splenectomy is also considered in some cases as second line or third line treatment during pregnancy, especially in the case of rare refractive ITPs. And 70 to 75% of the pregnant women have benefited from it. Romiplastim, which is a thrombopoietin receptor agonist, from the name itself, it shows that it increases the platelet count by acting on the megakaryocytes. So the dose is 3 to 4 micrograms per kilogram per week, and reaction time is 5 to 8 days. And it has given the reaction rate of 95%. When we consider ITP in pregnancy, fetal complications is another concern. Fetal complications like thrombocytopenia, reversible bone marrow fibrosis, and thromboembolic events are main concerns. In neonates with less than 30,000, we give IVIG and platelet transfusions. Before I conclude my presentation, I would like to tell you that when there is an ITP during pregnancy with no bleeding manifestations, we need to closely monitor the patient for the platelet counts. That is like monthly for first 2 trimesters, fortnightly for the third trimester, and each week nearing the term. And when should we start treatment? When the platelet count is less than 20,000 and there is a suggestive bleeding also there, before 36 weeks, and less than 30,000 in cases around 36 weeks. These are my references. Thank you again for your patient listening.
That was a good presentation on the ITP transfusion. Actually, the indication for transfusion in ITP is controversial, no?
Yes, ma'am. Actually, the case was, even though the case was taken by our hematologist, since we don't have an admission there, we have to admit the patient in gynecology. So every time there is, we have multiple inputs coming from all the consultants. So
Yes.
they only insisted on this RDP in the initial stage. When we could counsel the consultant and also the PGs over there about the controversial platelet transfusion in the case of the patient, ITP.
Okay, thank you. Any other medication other than this rituximab? Any role of Dapsone? Can you comment on that?
Sir, ma'am, since it is a pregnancy,
Yes.
we cannot. We have actually went through all the drugs that is safe in pregnancy. The MMF was discontinued in that name only because there was a controversy that in the first two trimester only, it is, according to the studies, it is first 2 trimester only we need to stop it. But the patient presented to us in the 3rd trimester. But still, since there was a controversy, we from the hematology side, we just stopped the medicine and started on rituximab.
Any questions from the audience? Okay. We'll move
Thank you
to
all. Thank you, ma'am.
Good morning, all. I'm Dr. Minu. Recently joined as a specialist from Master Medicity Kochi. This is a difficult case of technical challenges that we faced in a sickle cell patient that we did a stem cell harvesting. A few words in sickle cell. It refers to an inherited disorder with mutation in the gene encoding beta subunit of hemoglobin, and it causes hemolysis, recurrent vaso-occlusive crisis, and leading to a chronic endocrine damage. The interesting fact is that in South Asia, the highest prevalence is in India with 20 million cases, mostly in Gujarat, Madhya Pradesh, and in southern part of Odisha. So a reduction in early mortality was achieved by newborn screening, penicillin prophylaxis to reduce the chance of infection, blood transfusions in case of crisis, and hydroxyurea treatments to increase the level of HbF. Complete chance of cure can be achieved only by a stem cell transplantation or a gene therapy. Now coming to the case proper, we had a 10-year-old child from overseas with recurrent episodes of vaso-occlusive crisis, long-standing fever, joint pain, and backache for a period of 8 years. She was investigated in the home country and was diagnosed as a case of sickle cell disease and was on hydroxyurea and penicillin. She underwent a haploidentical transplant with father as the donor and at the age of 7 years, but had a primary graft failure. The current investigation showed a HPLC of HbF with 11.1 percentage and HbS of 83.8 percentage. That is the villain here. Red cell indices were grossly normal with an increased RDW. Before moving on to an allogenic transplant, we did a rescue collection for the child if at all it is needed for the future. So we pre-medicated the child with GCSF and plerixafor, and we had a pre-CD34 count of 26 cells per microliter, and the target was set for 4 to 6 millions. The cytopheresis was performed using a spectroptia system. The collection port was positioned optimally, and the parameters were further adjusted by the colorogram provided. And AC ratio was 1:12 when collection pump flow rate was 1 ml. Calcium gluconate was supplemented. PRC priming of the circuit was done, and the venous access used was bilateral median cubital vein. Everything was moving smoothly until 2 hours. After 2 hours, we faced difficulty in maintaining the interface. On the left-hand side, you can see the normal interface, and on the right, it is the loss of interface. So as usual, we check for the patient. Was the patient moving? Was there any difficulty in the venous access? So everything was perfect. There was no kink in the line or anything. So on close examination of the circuit, we noticed that there were multiple clots in multiple locations. So after discussing with the Optia team, we flushed the whole circuit with normal saline and increased the AC ratio also. Still, we couldn't proceed with the procedure. As you all know, with decreased oxygen tension, the RBC sickling will increase. So the RBCs in the circuit underwent more sickling and thereby closing the clot. So the whole tubing was clogged and we had to abort the procedure. At a product volume of 238 ml, we could get only 1 million of the product. So after discussing with the primary team and the parents, we went on for a red cell exchange. Gender, height, weight, everything was entered, and the fraction of cells remaining, that is, the red cells remaining in the patient circulation at the end of procedure was entered as 30%. Desired final hematocrit was set as 30% and 100% fluid replacement was done. A red cell volume of 1977 ml was removed and a replacement of 1685 ml was given with leukoreduced, cross-match compatible irradiated PRBCs. Here also calcium gluconate was supplemented and the patient was hemodynamically stable throughout the procedure. The result is that hematocrit was maintained throughout. The HbS from 83.8% fell to 12.5% after the RC. That is, an effective reduction of 85% was achieved. Now, after that, we went on for a stem cell harvest again. This time it was uneventful and we could collect 5 million per kilogram body weight at a product volume of 428 cells per microliter. For the allogenic harvest, the donor was a brother with a haploidentical match and the child had antibody against the donor. So we went for a series of plasma exchanges. 5 sessions of plasma exchanges were done on every alternate day. PRC priming was done as the body volume was less. And after the plasma exchange, we went on for an allogenic stem cell transplant with a CD34 dose of 10.8 into 10 to the power 6. And the patient had a neutrophil engraftment on post-transplant day level. And the chimerism analysis on day 30 and day 60 showed 100% of the donor cell. So what we are trying to say is that high HbS value is always a tedious task for us. So always try to keep RC in mind before going for a stem cell harvest with a child with or a patient with high HbS levels. I thank the Tmas members, my HOD and Dr. Ganesha for this opportunity.
It was a good case that you presented. You, for RBC exchange, you did RBC exchange,
Yes.
leukoreduced.
Leukoreduced.
Okay then. Any questions?
After the first failure, sir, first on the next day. On the first day, the transplant was done, it was a failure. On the next day morning, RBC exchange was done with the same venous access, and on the next day, transplant was done.
After RBC exchange, the CD34 didn't drop much?
No, sir, no.
It didn't drop much?
No, sir. Another dose of Perixa was given actually.
Plexifer was given?
Yes, sir.
Okay. So it was a GCSF based mobilization or for the first cycle?
GCSF and Perixa.
First cycle? First mobilization?
GCSF and Perixa was given.
For the first cycle also, 26 cells were shown, no?
That
time also Plexifer was given?
Was given. The next time only Perixa was given. GC was not continued.
Like with Plexifer, 26 seems to be lesser, right?
Yes, sir.
It's a nice presentation.
Thank you, sir.
Good morning, all. Myself, Dr. Lakshmi. I'm a PG resident from Department of Transfusion Medicine, IMS in Sam Hospital, Bhubaneswar. Here, I'm presenting a case of therapeutic plasma exchange in atypical hemolytic uremic syndrome in a pediatric patient. I'm presenting a case of 11-year-old female child. Her weight was 60 kg, height was 152 centimeter, and there was no relevant history of bleeding in the family and no relevant past medical history except for that she was hospitalized for pneumonia at 22 days after birth, for which documentation was not available. She presented with fever for 1 day, which resolved with oral medication, and non-bilious, non-projectile vomiting for 3 days, 2 to 3 times per day. And abdominal pain was there, which was periumbilical, non-radiating, intermittent in nature, high-colored urine for 2 days, joint pain with petechial rash over both lower limbs for 2 days. There was no history of loose stool, no history of recent drug intake or oral ulcers or cough. So the patient was admitted in pediatric ward. She was kept on nil per oral, and she was given oxygen via nasal prongs, IV antibiotic and other supportive treatment. But her condition worsened. She became tachypneic, pale, with decreased urination and persistent abdominal pain, and she was shifted to pediatric ICU. In pediatric ICU, she was kept on heated humidified high flow nasal cannula as she was having respiratory distress with severe anemia. And chest X-ray taken showed massive cardiomegaly. There was tender hepatomegaly and bilateral pitting edema. And atypical hemolytic uremic syndrome was suspected with impended congestive cardiac failure. At that time, her hemoglobin was very low, 4.5 gram per deciliter. Total platelet count was around 10,000 per microliter. And she was given, in view of this, she was given 350 ml PRBC and 10 RDPs on day 1 after admission. But the hemolysis was ongoing and there was thrombocytopenia. The platelet count dropped to 4,000 per microliter despite receiving the platelets. IV steroid was started, and under all aseptic precautions, central line was put on right internal jugular vein on day 2 after admission. In order to rule out the infections, we did MPICT, leptospira, scrub IgM and dengue profile, and all were negative. Renal Doppler was suggestive of bilateral acute kidney injury. There was minimal ascites and bilateral pleural effusion. Echo showed normal LV ejection fraction and there was no abnormality. Transfusion medicine consultation was given and she was planned for therapeutic plasma exchange and was advised direct Coombs test. On day 3 after admission, the first cycle of therapeutic plasma exchange was done and subsequently 2 cycles were done on next 2 days. How the diagnosis was made: presence of thrombocytopenia, that is platelet counts were 4,000 per microliter, a negative Coombs test, anemia, and renal Doppler showed bilateral acute kidney injury. LDH was elevated 1,101 unit per ml, and there was no history of diarrhea or evidence of infections, and hence HUS secondary to STEC was ruled out. Factor H autoantibody was negative, and complement gene mutation study could not be done. Hence, a typical HUS diagnosis was made through exclusion. Details of therapeutic plasma exchange. We performed a TPE using Spectra Optia apheresis system thermo-BCT with right internal jugular venous axis, and CPDA solution was used as anticoagulant in a ratio of 1:12. Whole blood inlet and collection flow rates were adjusted based on patient's parameter to mitigate any procedural complication, and complete blood counts were monitored pre and post procedure. FFP was used as a replacement fluid and frequency of cycles was daily. Plasma volume exchange was 0.95. So here are the details of removed plasma and replacement use, runtime, anticoagulant, and plasma volume exchanged. So as shown by the blood investigation, there was a increment in hemoglobin after the third cycle of therapeutic plasma exchange, with a total platelet count of around 2.46, hemoglobin 9.7, and peripheral smear showing schistocytes less than 2% and a decreased LDH value of 246 unit per ml. After 3 cycles of therapeutic plasma exchange, we stopped the plasma exchange. The outcome post-plex CBC showed increased platelet count with decreased schistocytes on peripheral smear and improved RBC with decreased LDH value. Homocysteine levels were increased and vitamin B12 and folic acid supplement were added accordingly. The clinical condition of the patient improved and the vital signs were improved. Schistocytes less than 2%, platelet count more than 1.5 lakhs, and LDH 246 unit per ml, and creatinine value decreased. With this, we stopped the plasma exchange and the child was shifted to PHDU. And at that time, she was afebrile, orally tolerating, and hemodynamically stable, and she was discharged 2 days later. Other treatments received include oral prednisolone, IV antibiotic, and other supportive measures. And at the condition of the child at discharge, she was stable. Her vitals were stable. In discussion, early intervention with therapeutic plasma exchange can significantly improve prognosis, as shown by the clinical improvement in this patient. As there is no standardized approach, the duration and schedule of TPE for treatment has been empirically adopted, and plasma exchange proves superior for remission and recurrence prevention, potentially by removing the mutant dysfunctional complement factor H molecules. And this case underscores the effectiveness of TPE in managing the patient with atypical HUS, particularly when eculizumab is not available as in our setting. And this is the ASPA guideline for therapeutic plasma exchange in complement mediated thrombotic microangiopathy, and the category, it comes under category 3, grade 2C. These are my references. Thank you so much.
Thank you for the nice presentation. Can you tell me the rationale for plasma exchange in HUS?
In HUS, actually, because there is ongoing hemolytic anemia and thrombocytopenia, and atypical HUS is actually a diagnosis of exclusion. So in this case, because mainly we initiated the treatment was initiated as there was fall in platelet count, and
How will you assess the benefit from Plex?
um, in this
What do you
case,
expect after Plex? What do you expect?
we actually advise for follow-up. The patient is under follow-up right now, and after Plex, we actually we were trying to remove the dysfunctional CFH molecule. So after Plex, clinical improvement and increment in the platelet count and decreased hemolytic anemia as demonstrated by the decreased histiocyte count in peripheral smear.
Okay. Any question from audience?
You were doing a 0.95 plasma exchange, like if it is 1 to 1.5.
1 to 1.5.
But why did you go for 0.95? What is that? Almost all three procedures had 0.95, no? So is there any particular reason or like?
No, sir. Actually, we aimed for one volume exchange only, but it came to 0.95 approximately.
See, the problem is the range is 1 to 1.5,
1.5.
right? Even if you go a little bit above 1, that is fine, totally fine. Even if it is 1.2, no problem. But if someone asks you, like, when the guideline says that this is the like recommended frequency or like recommended plasma exchange, you are not reaching it, no. It is kind of suboptimal.
Very good morning, all. So I'll be discussing on a case which we had done for first time with the thalassemia setting. So it was a poor harvest of peripheral blood stem cells in a donor who is with the thalassemia trait. So and some lessons gained on it. So we all understand that mobilized peripheral blood stem cells through apheresis is a standard approach for collecting hematopoietic cells for hematopoietic cell transplantation. And peripheral blood CD34 cell count before collection still remains the better predictor for getting adequate yield or not following a stem cell collection. So here we discuss a case where there is an unexpectedly high peripheral blood CD34 count in the donor. It's a donor setting. So, but we would get a very poor yield despite having a high peripheral blood CD34 count. So on the pre-procedural workup, so the transplant type is an allogenic transplant. So the patient is a thalassemia major and the donor is a thalassemia trait. So, and the target dose required from the donor was like 5 million cells for the recipient body weight. So these are the patients and the donor demographics. So the patient is 4 years female and the donor is 3 years male. So the weight of the patient is 14 and the donor is 12. So the donor is a little smaller donor than the patient. And it is a case of a minor ABO incompatible transplant. So where the donor has a A group and the patient is a AB. So the antibody titer is 1 in 4. So we are not aiming for any modifications in the product. And the donors CBC, the hemoglobin is 8.8, hematocrit is 29, platelets 347, and peripheral blood CD34 count was 72. So for us, 20 cells is considered adequate, and this guy had 72 cells. And the WBC count after mobilization was 33,000. So in view of low weight, 12 kgs, and his hemoglobin is 8.8 and hematocrit 29, we did an RBC priming also. So parallelly, we did the other estimations also. On pre-workup, so the red cell volume in the child was 243 ml. So the percentage of ECB which corresponds for the stem cell collection is 35%. So we advise RBC priming when the percentage ECB is more than 10% in pediatric setting. So it is 35%. So we did a RBC priming, and the reconstituted whole blood had a hematocrit of 40%. So the blood volume to be processed was estimated using the well-established formula. So we understand that like 1.7 liters of blood volume from the donor should be able to get us 5 million cells for the patients. Since it was a case of minor ABO incompatible transplant, we try to maintain collecting from the middle layers so that we don't collect more amount of RBCs from the donor. So this is a standard practice at our center. So we used to collection using CMNC protocol using spectrometry equipment. So we aimed purity rather than the yield because it's a donor setting. So donor generally gives a better count yield. So on processing 1.93 blood volumes, that is like 1.93 liters of blood from the donor. So it took around 234 hours and the product volume was 100 ml. So we set our target as like 50, like initially we started targeting at 50 and later the collection preference was adjusted to 47. And surprisingly, the product content when we saw, the product had a CD34 count of 400 cells, only 5 times the concentration of peripheral blood. And when we see the yield, so what we got was only 2.5 million cells with respect to the patient's body weight. So normally in a donor setting, who mobilizes well, so we expect a very good collection of yield also. But in this case, either our prediction formula is wrong or something wrong with our collection. So that was the problem we found. And collection efficiency is supposed to be 21% here. In a normal setting, we get somewhere around 40 to 50%. So it is way below the like our routine practices. So when we try to analyze what were the factors, so few factors which comes in our mind is the timing of collection. First thing is like when was the chemo like mobilization given, drug given, and what time we started our collection. Ideally, collection should be started within somewhere around 4 to 12 hours. So and we were within the limits. So and our collection preference also was okay. Like if it is on 47, it is still optimal collection preference only. So and our blood volume process also is fine, but still all these parameters we could not find out what was the reason. Then we started working on the donor parameters. When we found the donor parameters, when you see the donor's MCV, it is 46. So his hemoglobin was 8.8, his hematocrit was 29, whereas the donor's MCV was 46. So it was surprisingly low for us. Though the donor is a thalassemia trait, so we don't expect such a low hematocrit in the donor setting. So when we started understanding why the low MCV has affected the yield. So we could found few articles on it. So the first article was poor harvest of peripheral blood stem cell donors with microcytic red cells, and there is also a study. It is a poor stem cell harvest may not always be related to mobilization. So it may be related to the patient's RBC per se. So what we understood is, so for an RBC like stem cells to getting collected, we first want the RBC bed to be formed in our apheresis system, followed by our Buffy code can sit on it and concentrate on it, and supernatant will be plasma. In these cases where there is a low MCV, so you don't get the MCV bed to be formed, and your stem cells will go below your RBC layer, and RBC will be above your stem cells or WBCs. So our collection preference of 47 or 50 did not work in this case in the microcytic setting. So I hope you understood. Normally RBC will be pushed outside, that will be in the bottom as per this colorgram, and your Buffy will be in the middle and plasma will be received. Because the MCV is so low, so their specific gravity is much lower than the WBC specific gravity. So the RBCs are on the superficial surfaces over the WBCs. So there is no clear demarcation. So your stem cells will always be intermixed with your WBC in this setting. So we discussed with few experts. So they suggested we should go RBC to be collected from a deeper into a RBC layer. So with that experiment, we also attempted a second procedure. So using the same mobilization protocol, we gave one more dose of GCSF. His peripheral blood CD34 count, it was in this second procedure, it was 68 cells, which is almost similar to the first procedure. And the blood volume processed is almost similar. It's like 2 liters, close to 2 liters. And the product volume was 68. This time we kept our collection preference. We started with the 20 and we went up to 15. So way below the 15. And so this was the first procedure. So where you can see the color, it was our first standard one. And with the second procedure, we went deep into the RBC layer. So when we saw the yield in the product, so you could see the WBC count. In the first procedure, it was 54,000, while in the second, it is 122 lakhs, 1.22 lakhs. And CD4 34 count per microliter, it is 400 in the first one and 775 in the second one. And the yield, it is 2.5 and it is 3.5 in this one. And the collection efficiency, it has close to doubled. So and the RBC content in the product also, if you see, by going still deeper also, we did not collect more RBCs because RBCs are like they haven't sedimented. So this was one thing. So the way forward is when we attempt, like we usually don't take MCV into picture when we do a stem cell collection. So we started introspecting ourselves. The way forward is always introspect the MCV values of the donor and the patient, and reducing collection preference as low as 20 could help you get you a good target yield. always process a larger volume because your prediction formula will not work in your thalassemia setting. And increasing the amount of collected RBC buffy, like buffy code should also be considered. And there are settings like where thalassemia patients, they undergo gene therapy. So in that setting, always better to do a red cell exchange before attempting a stem cell collection. So conclusion, overt RBC abnormalities such as in thalassemia trait have a very low MCV, may account for a failure to collect circulating CD34 cells by using standard protocols. So we should try to modify our settings and do not adopt the factory settings as such in thalassemia patients. So thank you for your patient listening.
It was an excellent case report. Anyway, you had this. What were the hurdles that you came across from the donor, the other sibling, while doing the collection of stem cells? It's
That's
also a
what our
small
mistake.
boy, no?
On the donor, we usually don't look at the MCV values. So we just look the hemoglobin, hematocrit, and decide on RBC priming or not or not. So it's the first time we do it on a thalassemia patient. So we usually do it on malignancy settings and Fanconi's anemia. So thalassemia is it's the first time we are undertaking stem cell transplant. So it's also learning lessons for us. So on a donor thalassemia trait, despite thalassemia trait, his MCV was low. Even it surprised the clinician also. They also overlooked his MCV, but he's still in asymptomatic. He doesn't require a transfusion. He's a transfusion independent thalassemic trait. So that's why he's a fully matched sibling donor. So they proceeded to transplantation.
Small boy, no?
Sorry, madam?
He was also a small boy.
Yes, no, he's like 4 year, like 3-year child, madam.
Was cooperative.
Yes, madam. He's fine, madam. For 2 procedures, he was fine. So very nice child.
Thank you so much. Any comments from the audience?
Madam, I went, one article was on that. So what they said was they classified low MCV in different levels. So normal MCV is somewhere around 80. Like 70 to 80 they classified as low, and see, like 50, like 60 to 80 is moderate, and less than 60 they classify it as like severe. So what they found is in the last two category, the low, like moderate and very low. So they told you have to start collecting from the RBC layer. When it is less than 60, definitely you have to collect from the RBC layer because your stem cells will be heavier than your RBCs in those settings. So like stem cells are basically mononuclear cells, so they are bigger cells. So their specific gravity will obviously be bigger than your RBCs, like dysmorphic RBCs. That is what they have written, concluded in that manuscript. So this is the first time we also had such a like.
This holds good for anemic donors.
Like what
as
I
well.
understood is,
and female donors.
ma'am, what I understood is this has been like this scenario is common in myelodysplastic syndrome and low MCV donors as well as thalassemias. So in all three settings, we should always try to collect from the RBC layer, not from the buffy layer.
Any other precautions while taking a thalassemia trait for
That's what,
serology testing?
like red cell exchanges, like priming should be done. What they suggested is if the MCV is so low like this, always attempt a red cell exchange first. As she did explain in the previous sickle cell, do a red cell exchange so that your RBC layers becomes normal. So you can attempt a collection properly. This is what they advised. But red cell exchange in a donor, asymptomatic donor, so like ethically it may not be possible. So that's why we went with collecting it low. But when you're planning prior, so you can always do an RBC exchange. So I told them like whether RBC exchange will affect our mobilization stem cells. They told mobilization is a continuous process. So you will still get your adequate peripheral blood CD34 count after red cell exchange. So they told on day 3 you can do a red cell exchange, and day 5 you can start your collection. There's no published literature on that. It's a practice where gene therapy is being planned for thalassemia patients. They do red cell exchange on day 3 and they start collecting stem cells on day 5. Thank you.
Good morning, everyone. It was an enlightening session. And I would like to invite Dr. Rafi to present certificates to all those who have presented their papers. Dr. Haripri. Dr. Haripriya. Dr. Arun Naik. Dr. Junit Thomas. Dr. Linda John. Dr. Akshaya R. Dr. Minu Lakshmi. Dr. Lakshmi GY. Dr. Mohan Das. The awards for the oral paper presentation will be given at the valedictory function. Thank you.
Participants in this row, others can sit here. So that yeah, we will leave one gap so that we understand the. I will tell you. Okay, the participants. Mic to Sheikh sir and Dawood. Sir, no.